So we're now going to cover some common clinical scenarios, and first of all we're going to have a patient with a cervical disc prolapse. So Tom's come to see me today in my consulting room. About 6 weeks ago he had a relatively abrupt onset of severe pain in his neck. He woke up with it one morning and couldn't remember doing anything unusual either the preceding night or in the week leading up to the onset. He noticed that his neck was extremely stiff, that he could hardly move his head at all, and over the next 48 hours he gradually began to develop pain radiating down through the shoulder blade and shoulder itself, and then down the outside of the arm into the thumb and first finger. The pain is very severe, it's shooting pain, made worse by any sort of movement, either of his head or of his arm. Relieved to some extent with anti-inflammatories and stronger codeine-based analgesics. So he put up with this pain for the first 3 or 4 days, wasn't getting any better, went to see his general practitioner who increased his analgesics and also recommended some physiotherapy. Now the physiotherapy was helpful in some respects in that it helped with the neck pain, but unfortunately every time he went to go for physiotherapy it made the arm pain worse. He also noticed that every time that he coughed or sneezed or was straining, for example passing stool, that the pain in his arm would get much worse. So clearly the GP was worried that he might have a cervical disc prolapse, and that's why he's been sent up to see us today. So 6 weeks of severe neck and arm pain that hasn't responded to conservative measures. So I'm going to examine Tom, and the first thing you notice, he's holding his head very stiffly, and when I feel for the muscle tone, these muscles are very, very tight and in spasm, and I can hardly press into them at all. Then if you turn this way, and when I come to examine Tom's neck movements, you'll see that they're very, very restricted. So try and put your chin down on your chest, and he really doesn't like doing that. Very restricted. Look up towards the ceiling, and again he can just get his eyes above the horizon, but any movement of the head is bringing on some pain in his arm. And often the movement that makes the pain worse is lateral flexion, particularly towards the side, the affected side. So just try not to hurt you, but just try and move your head towards the affected arm. And he really doesn't like doing that, and as he does that make the pain in your arm worse? Okay, and then move your head, try and bend towards the other side, a little bit more movement there, and then look straight ahead. And you'll find that the rotation is often reasonably well preserved. If you turn your head to the left, yeah, and then to the right. And that's not making the pain in his arm worse. So having established that the neck has got muscle spasm with a reduced range of movement, we're now going to look at the neurological findings in the arms. So I think perhaps if you lie on the couch for me. Now Tom has described pain in the C6 dermatome. So the findings that we might expect to find are that the supinator reflex are depressed, and he has some altered pinprick sensation over the thumb and first finger. So I'll just check his reflexes now. So looking for the biceps, which is predominantly C5, which is present, and then going for C6, and the reflex is not there. And looking at C7, and there's a little reflex there. So we found that the supinator reflex is absent. It's quite unusual with a C6 root problem to find weakness in the arm. Sometimes you'll find a little bit of weakness of elbow flexion. Just bend your arm up towards you. No, but it's not there. He's got a good power of elbow flexion. And we'll just test sensation. So you put your hand into this position and always test the area where you expect the pinprick to be normal. Can you feel the pin there, Tom?
Yeah.
That's fine. And then if we work our way down through the C5 dermatome, and then as we come down into C6, particularly the thumb and first finger, you notice that alteration in pinprick sensation? Does it feel a little bit different?
Yeah, it's less sharp.
Less sharp, that's right. And then when we come over to here, sharp again?
Yeah.
So we're into C7 here, but when we test in C6, you notice a little bit of blunting of the pin. The natural history of cervical disc prolapse is usually very favourable. Most patients will get better, provided they are prepared to wait. By 6 weeks, roughly 50% of patients with radicular pain in the arm from a cervical disc prolapse will have made a complete recovery in the sense that their arm pain will have resolved. By 3 months, 70% of patients will be better, and by a year, 95%. But for those patients who have severe arm pain, which is not settled in the first 6 weeks, you need to consider alternatives to conservative treatment. And the two main alternatives that we can think about are either undertaking a cervical nerve root injection. The advantage of that is it will provide some pain relief while we're awaiting the natural resolution of the problem, or if the pain is severe and if an MRI scan has revealed a significant disc with nerve root compression, then an operation to relieve the pressure on the nerve root should be considered. And surgery these days is very safe and very effective, and we're looking to cure 95% of patients. So 95% of patients having an operation under these circumstances, we would expect resolution of their arm pain. And if you cure the arm pain, you almost always cure the neck pain as well. So what we'll do now is to examine reflexes. Now, reflexes can be extremely helpful in neurological examination, and sometimes they can be a little bit misleading. So every patient, you have to put what you find into context. And sometimes in very well muscled and fit individuals, paradoxically their reflexes are very difficult to elicit. So we'll start with the biceps reflex. So you need to put your finger on the biceps tendon and give a firm tap, and if you look carefully you can see a twitch of the muscle and a movement of the forearm. So that's the biceps, which is C5. Reflexes can be brisk in spinal cord disease, they can be absent in nerve root disease, and between those two extremes there is a variation of normality. So we'll look now at the supinator reflex. This is C6. Again, we're looking for a twitch in the muscles here in the forearm, and you want to do a firm blow to the radius, and you're looking for both a movement of the muscle and a movement of the arm. Sometimes patients who have upper motor neurone signs with spinal cord disease, when you hit the supinator reflex, you'll see a flicker of the fingers, and that's something to look out for. We'll now do the triceps reflex. Again, you need to be feeling the triceps tendon, which runs down to the olecranon process, and give it a firm blow. And you can see there both the muscle twitching and the forearm extending slightly. So Tom's reflexes are within the range of normal. So if the reflexes are all absent or all reduced, then that gives you a very different picture than if you find one reflex missing. And if you find one reflex missing in a patient with neck and arm pain, then that can help you localize the level. So if it's the supinator reflex that's missing, that's predominantly C6, and we would know that the C6 nerve root might well be involved in the causation of the patient's arm pain. If the triceps reflex is absent, then that's predominantly C7, and we'd be looking for a problem associated with the C7 nerve root. So, having covered the myotomes and reflexes in the arms, we can now use a pin to map out any possible sensory loss in the dermatomes. So if you get your patient to put their hand into the anatomical position and then start in an area that you suspect is normal. Tom, do you feel that as a sharp pin?
Yeah.
And then start examining the dermatomes, starting with C4. Do you feel that sharp?
Yep.
C5.
Yep.
C6.
Yep.
And C6, remember, comes down onto the thumb.
Yep.
C7 is the ventral aspect of the forearm, coming down onto the middle finger.
Yep.
C8, which is the medial aspect of the forearm, coming down onto the little finger, and coming up into T1, which is up in the axilla. Working down the thoracic dermatomes, T4 at the level of the nipples, T10 at the level of the umbilicus, and L1 in the groin. The next thing I like to assess is root tension. So in order to assess the so-called straight leg raise, which is probably best demonstrated from over here. So first of all, we want to make sure there's no problem with the hip. So I bend the thigh upwards, get the hip flexed, and then just check that there's a good range of pain-free movement of the hip. Because remember, there's a big overlap in patients with back problems and hip problems. And some patients who you think initially may have a back problem, it turns out that the underlying problem is with the hip. So always check the movements of the hip, abduction and adduction, feeling for any movement of the pelvis. Okay, so Tom's hip is moving nicely. Now I know that, it's safe to do a straight leg raise. And in the straight leg raise, essentially what you're doing is stretching the sciatic nerve and the nerve roots as they exit the lumbar spine. So as I lift the leg up, like so, a patient who's got radicular compression will develop pain that radiates all the way down the leg, often felt in the back as well, at a certain degree of elevation. Now that might be very low, at 20 degrees or so, it may not be until they're up at 60, 70 degrees. But the positive test is one in which the patient has pain in the back and the leg, which is brought on by raising the leg up and then is relieved by lowering it down. And as a further test of that, if you dorsiflex at the ankle, that puts a further stretch on the sciatic nerve, and a patient who's got irritation, compression of the lumbar nerve root the pain will be increased by dorsiflexion at the foot. Okay, you pop your leg down for me. Some of the patients that you'll be assessing with back problems are likely to be elderly patients who may have lumbar canal stenosis. Remember, this is the group of patients who present with neurogenic claudication, and by that we mean a combination of pain in the back, sometimes in the buttocks and down the back of the legs, made worse by walking and relieved by sitting down or bending forwards. Some of those patients, the symptoms of neurogenic claudication can be confused with the symptoms of vascular claudication, and so in this group of the group of more elderly patients, I always like to check that the peripheral pulses are present. So I feel for the dorsalis pedis pulse and the posterior tibial, and check that they are both present. So occasionally patients who present with neck and arm pain may also complain of symptoms in the legs. And under these circumstances, it's possible that the cervical disc is also causing some pressure on the spinal cord in the neck, and under those circumstances, a patient may have upper motor neuron signs in the legs. So the first thing we need to assess when examining the legs in this circumstance is the tone. So we'll just move the patient's leg around and assess the tone. And I do this both by doing these active movements and also by asking the patient to relax and lifting the leg and moving it around. In a patient with normal tone, you'll see that the foot remains on the couch, and in a patient with increased tone, just stiffen your leg up for me, you'll notice the whole leg is likely to rise as one. So having assessed the tone, you want to then look at the power in the legs, and a patient who's got a cervical spinal cord problem will have a particular pattern of weakness in the legs, and we call that the upper motor neuron pattern of weakness. And the muscle groups which are predominantly affected are flexion at the hip and dorsiflexion of the ankle. So, could you just lift your knee off the bed for me? So here I'm assessing the power of hip flexion, and then if you push your knee down hard into the bed, and that's hip extension. If you could just lift your leg up for me, so supporting the weight of the thigh, and if you could straighten your leg out for me, so that's knee extension, testing the power of that, and now flexion, if you bend the knee, and the power there. And then if you just rest your leg down, and then we'll look at the power of dorsiflexion, bend your foot up towards you, hold it there, and keep it there. And then push down against me, plantar flexion. You then ask the patient to invert the foot, so to turn your foot inwards, hold it there, then eversion is moving it outwards. Fine, so having examined the myotomes, we're then going to have a look at the reflexes, and in a patient with a spinal cord involvement with a cervical disc, then you'd expect the reflexes to be exaggerated and brisk. So we'll just lift the knee off the ground, try and relax for me. Feel for the patellar tendon, which runs between the patella and the tibial tuberosity, and then do the reflex. And here we have, Tom has just got a reflex there in his knee. We'll just compare with the other side. Just relax. And again, reflex just present. And as I mentioned earlier, there's a great variation in normality with reflexes, but certainly Tom's reflexes are not brisk. We'll do the ankle reflex. So looking for the Achilles tendon and striking a firm blow. And you can see both the foot moving and the muscle contracting. And the final test that you want to do when you're looking for upper motor neuron signs in the legs is to do the plantar response or Babinski response. You can use the bottom end of the tendon hammer. You must warn your patient that it's uncomfortable, and you're looking for the movement of the big toe. So a firm scratch, and you'll notice that Tom's toe moved down. And now I'm going to ask Tom to show you what happens with an upper motor neuron response. So when you scratch the bottom of the foot, and then the toe goes up. And that would be an upgoing plantar response, which is suggestive of an upper motor neuron lesion, which in the context of a patient with neck and arm pain could represent pressure on the spinal cord. So patients presenting with pain in the neck is very common in your surgeries, and very often the pain in the neck will be accompanied by pain in the arm. So when you've got a patient presenting with those sorts of symptoms, you're going to need to examine the neck and the movements of the neck, and also to do a neurological examination of the arm. So I always start by looking at the patient's neck. I'm looking for the alignment, how he holds his head, and whether the normal cervical lordotic curve is present. I then look for the muscles, looking for spasm, particularly in the muscles, and you can also feel for that. And having done that, I then palpate, and I'm looking for tenderness. So I press over the spinous processes, and then I also palpate deeply in the muscles, again looking for tenderness. We'll then get Tom to turn around now and face the camera. And then what we want to do now is look at all the movements of the neck. So we'll start, Tom, can you just look down and put your chin right down in your chest? That's flexion, and then I want you to look up at the ceiling and far back as you can, and that's extension. Then if you look straight ahead of you, Tom, if you look to the left side, so that's rotation to the left side, and then look to the right side, and rotation to the right. Look straight ahead, and then I want you to just tilt your head to the side. This is lateral flexion. Try to put your ear as close to your shoulder as possible, and then the other way. Good, so that's looked at all the movements of the neck. Now, as you all know, there's often a big overlap between neck and shoulder problems. We're not going to cover the shoulder in any detail today, but very briefly, what I do with my patients who present with neck pain is also get a very quick feel for how their shoulders are working. So can you just put your hands behind your head, like this, go over the top, just to scratch your back. Okay, and then come back round the other way, and push your hands as far up your back as you can. So by doing that, we've looked at active movement of the shoulder, and if you just turn around for us, Tom, if he can put his arms all the way up there and then go back to your original position from the top, go around and put your then that's a very quick way of illustrating that the shoulder has a full range of movement. And it's important to exclude the shoulder as the source of pain in this group of patients. So we're now going to move on to examination of the lumbar spine, the typical scenario being a patient who presents with either back pain or back pain and leg pain, or other symptoms such as difficulty walking, sensory disturbance in the legs, and very rarely disturbance of bladder or bowel function. So when I examine someone's back, I always ask them to turn around and look at their back in detail. I'm just going to slip your pants down a little way there, if that's all right. And the first thing I look at is the alignment of the lumbar spine. So if we get Tom just to turn around a little bit further, you can see that the lumbar spine normally has a curve in this direction, which we call the lumbar lordosis. Just to remind you, the lordosis is the curve in that direction. In the thoracic spine, we normally see a kyphosis, and then we get another lordosis in the neck. So I'm looking for the presence of the normal lordosis, and I'm also looking for the vertical alignment of the spine. Any lateral curvature we call a scoliosis. Sometimes a scoliosis can be a structural problem, for example, young girls with adolescent idiopathic scoliosis, and sometimes it can be secondary to muscle spasm, and that's probably the group of patients you'll see much more of. So if you have asymmetrical muscle spasm, then the patient can tilt to the side, and you end up with a curvature, a lateral curvature in the spine. So you've just come back into the neutral position for me. So having looked at the spine, I then like to palpate to have a good feel. I feel in the midline, the spinous processes, looking for tenderness. I'm also looking for the little step that you might feel in a patient with a spondylolisthesis. Having done that, I then feel for the paraspinal muscles, again trying to assess the tone of those muscles, looking for spasm in the muscles, and also tenderness. So having done that, we're then going to ask Tom to bend forwards, and we're going to look at the various movements of the lumbar spine. So if you bend forwards, and can you touch your toes? So go down as far as you can. And this is flexion now of the lumbar spine. You'll note that most of the flexion movement occurs at the hip, but patients also, some of the flexion as they go forwards occurs in the lumbar spine. And if you want to measure that formally, you can mark the spinous processes with a marker and see how the distance between the spinous processes changes between forward flexion, okay, and stand up for me, and then bend yourself backwards, extension. It's very useful, and then stand up straight for me. Extension is a very good thing to assess for two reasons. Patients who have facet joint pain, often their pain is made worse in extension. But I think more importantly, patients who have nerve root compression, and often patients who have narrowing of the lumbar canal, spinal stenosis, really don't like bending backwards, and they will resist attempts to make them extend their lumbar spines. The reason for that, of course, is that when you bend forwards, just bend forwards for me, Tom, then you open up, you stretch the ligamentum flavor at the back of the canal, and that pulls the ligamentum flavum out of the canal and increases the cross-sectional diameter of the canal, only by a small degree, but just enough to relieve pressure on nerves. So that's a very important thing to look for. I then ask the patient to bend to the side, looking for lateral flexion, and then to the other side, and then we look for rotation. So I just put hands on the pelvis, and then if you just twist your upper body to one side, and then to the other side. And you'll notice that actually there's very little rotation occurs in the normal lumbar spine. The rotation that does occur occurs in the thoracic segments. So having looked at the movements at this stage, I'll also check for perianal sensation. So I get a pin, obviously warn the patient. So I'm just going to test sensation over your bottom, don't be alarmed. Can you feel the pin there?
Yeah.
On both sides?
Yeah.
Great, if you'd like to pop your pants back up for me. So having examined the movements of the spine, we can turn around please. And the best test of the power of the ankles is actually to get your patient to just hold my hands for balance, and if you can stand up on your tiptoes, and that's plantar flexion, and if you just stand on one foot, and this is how you can pick up a very subtle weakness of plantar flexion. If the patient's unable to stand on one leg in this position, then they'll have a weakness of plantar flexion. Just do it on the other leg for me, up on your toes and stand on one leg. Obviously help them balance, because the balance is quite difficult unless they're a ballet dancer. And down you go. And then if you just lift your toes off the ground with one foot, just one at a time, that's looking for dorsiflexion on both sides. So we'll start with abduction of the shoulder. So if you put your arms up like that, this movement is controlled by the C5 segment of the spinal cord. When Tom adducts at the shoulder, so bring your arm back in towards you, back in towards the body, that's controlled by the 6, 7 and 8 myotomes. Thank you. Relax, Tom. What I want you to do now is bend your elbow upwards, so bend up towards you. I'm testing his strength there, and that is the cervical 5 and 6 segments controlling that. He's now going to push his arm away, extension using triceps, and that's the C7 and 8 segments. Okay, could you make a fist for me? So if you cock your fist up, bend it up towards you, this movement is controlled by C6 and C7, and extends, and again C6 and C7. Put your fingers out straight for me, Tom. And now if you grip my finger tightly, try and hurt me. So these are the long flexors of the fingers, and that's the C7 and 8 segments. And if you spread your fingers and keep them straight, stop me bending them, and again, that's C7 and 8. And I'm sure you'll all remember that the intrinsic muscles of the hands, if you spread your fingers apart and pop your thumb up towards the ceiling, these intrinsic muscles are all controlled by the T1 segment of the spinal cord. Good. We'll now have a look at the dermatomes. So can I just put you into what we call the anatomical position? And if you just turn to the back. So C1 doesn't have any dermatomal representation, but coming up over the back of the head and behind the ear is the cervical 2, the second cervical segment. C3 forms a ring a bit like a choker around the neck, and then C4 coming down as a cloak onto the shoulders. Tom, if you could face the camera now for me and put your hand into this sort of position. The C5 dermatome comes down the outside of the arm, just beyond the elbow, into the top of the forearm. The C6 dermatome runs down the outside of the forearm to the thumb and involves the first finger as well. The C7 dermatome runs down the front of the forearm, and if you can remember, that's the middle finger is always supplied by the C7 dermatome. The C8 dermatome runs on the inner or medial aspect of the forearm down to the little finger and running up onto the medial aspect of the arm, and then the axilla is T1. So remember that discrepancy between this sensory representation of T1 being in the axilla and the motor being in the intrinsic muscles of the hand. We might as well just work our way down the dermatomes. So thoracic 4 comes at the nipple line, thoracic 10 at the umbilicus, and lumbar 1 in the groin. We can now look at the myotomes controlling the leg movements. So Tom, if you could just lift your knee up for me, just one of them, that's fine. If you lift them both up, you'll fall over. And these are the L2 and 3 segments of the spinal cord, controlling obviously the L2 and 3 myotomes. Now, just put your leg down, turn around slightly, and then when you bring your leg backwards, so just bring your leg backwards, that's extension of the hip, and that's controlled by the L4 and L5 myotomes. Okay, if you can face the camera again, just want you to lift your knee up like that for me. Good. And now I want you to kick the lower part of the leg forward. So that's extension of the knee, and that's controlled by the L3 and 4 myotomes. And then we'll do flexion at the knee, bring it back, and that's controlled by the L5 and S1 myotomes. Down to the foot now. Dorsiflexion of the ankle, so just lift your foot up like that, is L4 and L5, and then plantar flexion is S1 and S2. We'll now have a look at the dermatomes. We've already mentioned that the L1 dermatome covers the groin, The front of the thigh is L2. The front of the knee is L3. The inside of the calf is L4. The outside of the calf, running down onto the dorsum of the foot towards the big toe, is L5. Turn around slightly for me, Tom. The S1 dermatome covers the little toe, the outside of the foot, turn around a bit further, and comes up over the back of the heel up to midway up the calf. The S2 dermatome then runs up the back of the calf and back of the thigh, and then you'll remember that the perianal area is covered by the S2, 3 and 4 dermatomes.